sulcus, but once you don't have support, there comes the other alternative techniques like the iris suturing. So the indications: insufficient capsular support, primary IOL opacification where you have to remove the entire bag. You can do it as a primary and secondary procedure as well. The contraindications for any iris related techniques like the iris claw, this is any uveitis histories, multiple sphincterotomies, atrophic iris, corneas with hazy views, it is better to avoid these techniques. So coming to the surgical technique of iris fixation, so this is a single haptic fixation where you can see the image describes there is partial capsular support. The other side you can fix it to the iris, and the side where the support is there you can leave the haptic in the sulcus. So this is a long curved needle attached to a 10-0 or 9-0 Prolene suture. So you take the bite at the periphery, at the limbus, so that the needle passes through in the mid periphery of the iris. And this is a little bit blind procedure. Since the needle is curved, a small twist of your arm practice in the wet lab will give you that it reaches the other side through the limbus outside. And then the next step is always after you are taking the bite, make a paracentesis right in between the two suture points. Make sure you do not cut the suture while doing this step. This mainly is to externalize the sutures at the end and tie the knots. So now you have a loop, a suture underneath the iris. So using a Kuglen's hook, a gentle tap is given on the iris and it is pulled outside through the sclerocorneal or clear corneal incision. You can see the loop coming out of the eye, following which a 3-piece PMMA or 3-piece acrylic lens, whichever. I wouldn't prefer using a foldable single-piece intraocular lens. Any PMMA lens or a 3-piece acrylic lens will be the ideal lens to do. So here what we do is we loop the same around the haptics couple of times, 5-6 times, and then make sure you pull the loops all to the optic haptic junction. If you do not do that while placing the IOL, there is a high chance that the loops will slip and the IOL might drop. So once the loops are tightly anchored at the optic haptic junction, the right side haptic where the capsular support is there, it is placed in the sulcus, and simultaneously the trailing haptic is not dialed. You should, it's a very important point. When you dial, what happens is the loops tend to slip away and fall down. So always pronate the haptic, release it underneath, and simultaneously pulling the suture which is closer to the optic haptic junction which is coming out of the eye. That will anchor the loops at the optic haptic junction very tightly. So now that the IOL is positioned inside, what we have to do is trim the suture on the exterior which is coming out of the limbus. Trim it, interiorize it by using a spatula or Kuglen's hook. Once both the sutures are in the anterior chamber, we have a common paracentesis in the middle. So you bring both the sutures through the common paracentesis. So the instrument we need to do this is a Kuglen's hook is very important. You cannot use a Sinski or anything. It is always important to have a Kuglen's hook. So once both the sutures are there, you tie 3, 2, 1. And how do you tie the suture is you do not crush the iris tissue. The iris tissue in between the two suture areas are going to be loose. So at the end of surgery, you will see a small parabola of the suture. If you are going to crush the iris tissue, you are going to have a very tight suture. What is going to happen is you are going to have tilting of the intraocular lens. We are trying to position the IOL at the PC level, as a regular in the bag positioning. So the IOL has to be a little bit loose for this to be there. So make sure if your iris is crushing, make sure you loosen it up. So this takes time. This is the couple of cases the learning curve is a little longer for this technique for this one reason. The knots are placed and they are pushed inside. They are trimmed and pushed, following which viscoelastic is done. The other important point is always do your vitrectomy prior to placing the intraocular lens or taking the suture bite. These sutures are so thin. If you have a small vitreous strand at the end of surgery and try to do a vitrectomy, there are chances that you cut the suture and you have to repeat the entire procedure. So make sure you do a proper thorough anterior vitrectomy and then you go in for the iris fixation. And this is just another scenario where you have cases like this. You can do a double haptic fixation. Same thing. You use 2 curved needles on either side. Make sure they are 6 clock hours away from each other. You bring both the loops outside, and then both the haptics are anchored to the loops. They are positioned inside. The same procedure is done. So it can be done as a double haptic fixation also. The postoperative results are surprisingly nice. You have clear corneas. The postoperative, the positioning is not so close to the iris. It's a little bit posteriorly positioned. So iritis complaints are also very, very minimal. The advantage, like I said, all you need is just a 10-0 Prolene with a long curved needle. You don't need any specially designed intraocular lenses. The disadvantage is it's a complex procedure. The learning curve is steep. It takes a lot of cases to learn. Decentration and tilt can happen if the sutures are a little bit tighter. Coming to the next technique of iris claw. Preoperative workup, make sure the iris tissue is proper. In PCRs or in whole bag removals, when you're doing it as a primary and secondary procedure, make sure that the pupillary mobility is there, iris integrity, texture is there. Contraindications where the prognosis is bad, endothelial cell count is less, inadequate iris tissue, and also in distorted pupils, patients with iridodonosis and iridotomy, so please avoid the iris claw lenses. It might be a very easy technique, but not in all patients do you give consistent results. So you can do anterior fixation and posterior fixation. It's always safer to have an anterior fixation. This technique you require the iris claw lens, which is a special lens, PMMA lens, Clayman forceps, and a good anterior vitrectomy setup. So we'll just go into the surgical video. So this video is by Dr. Fatima Madam. So once you have completed proper anterior vitrectomy, make sure you make the paracentesis exactly 6 clock hours away. Position the intraocular lens in the anterior chamber, the iris claw lens in the anterior chamber. Make sure you have enough viscoelastic. Using a Clayman's forceps, it is held very firmly, and then one haptic is introduced underneath the iris. Sometimes you might have to use a Kuglen's if the pupil is too small. Once one haptic is underneath, through the paracentesis on that side, use a spatula or a Sinski's hook to nudge the iris between the two claws. And then similarly, you have to switch hands to the left hand, hold the IOL properly, introduce it underneath the iris, and then nudge for the second fixation. And then do a proper viscoelastic wash and close the case. Outcomes can be like this in most of the cases. You'll have proper dilatation also, but it does not happen in all the cases. If this technique is proper, it can happen. The other complications and difficulties is bleeding, sometimes IOL drop, DM detachment. In traumatic cataracts where you have traumatic mydriasis, where you cannot place the intraocular lens, where the pupil is not constricting, this technique cannot be done. The other common thing is cat's eye pupil. On table you can see this happens when both the fixation are too close to the pupillary margin. When the iris tissue is too close, then probably you will have this complication. Postoperative complications include ovalization, disenclavation, dislocation, endothelial loss, cystoid macular edema. It's a little common in this technique. So it is a good alternative technique. It has a short learning curve, reduced surgical time. But the thing is, ideal case selection is very important, proper technique is important, because once you enclave it in a wrong position or a little bit decentered, you have to cut that iris to remove the IOL tissue. So I'm not a big fan of the iris claw. I will just show you what I do right now. So in PCR cases as a primary and secondary procedure, so this is after cataract extraction, after anterior vitrectomy, I use a long spatulated needle which is 150 microns, which is attached to a 7-0 Prolene suture. 6 clock hours apart, 1.5 to 2 millimeter depending upon the axial length. The sclerotomies are done, and both the needles are exteriorized through the sclerocorneal tunnel. I use a PMMA lens, single piece or 3-piece. The sutures are passed from above to below. The needles are trimmed and flanged, and the IOL is introduced into the eye. Once it is introduced, mild decentration is done towards the first site of flanging. The suture is trimmed to about 1 millimeter. It is flanged, and to bury it, the opposite side suture is pulled while simultaneously lifting the conjunctiva antenons. Now you can see that one side is flanged and buried. The second side, make sure you hold the forceps indenting the sclera a little bit, trim, flange, and then conjunctival closure is done. Thank you very much.
See this long one with curved, this one Oralab makes the long curved needle?
Yes, sir.
Oralab makes.
Yes.
Thank you, Dr. Vivekanandan. I think excellent display of techniques and pros and cons of iris fixation and the sterile fixation. We learned some new techniques today. We started at 10:10, so we have another 15 minutes to go for this course. So the audience, if you have any questions, we can take that now. post-op medications. Yeah. So the one thing we normally do for all post-op capsule rupture because of high risk of cystoid macular edema, we would add an NSAID for sure. So any NSAID, Nepafenac, Ketorolac, we would give that for 1 month or 6 weeks. That's one thing we would add. If there's a lot of manipulation, I also add a course of oral antibiotics for about 3 days, just as prophylaxis. Though we don't have any strong evidence, we just do that when there's a lot of manipulation. For all eyes with lot of manipulation. If it's a small PCR, no vitreous loss, it does not matter. Besides that, the medication strategy would be the same, no change. As in all patients, we do give intracameral moxifloxacin on the table at the end of surgery. We give a little higher dose when we have a PC rent. So normally the antibiotic in the eye, like we use Oromox, in 0.1 ml, it has 500 mcg which goes into the eye. But if you're going to go in a patient like now to get 500 microgram, we give about 600 microgram, which is 0.12 ml. In a PC rent eye, I would give 0.15 ml of the Oromox or Vivekanandan or whatever you're using. This way you have 750 mcg of the drug going into the eye. So 750, not all of it goes in because as you're injecting you lose some. So stepping up a little more is still fine and safe because we know that in PC rent eyes you do have chance of endophthalmitis. Besides this, we continue with a normal regimen of steroid and antibiotic for the post-op, but in case post-op you find that the patient has more inflammation, do step up, which we'll only know in the post-op period. Other thing is to manage the IOP. So we don't give any Diamox or any AGM prophylactic because sometimes you also can have hypotony in these PC rent. The wound, if it's not been done well, if you have extended the wound or too much of vitrectomy, you can also have hypotony. So only in the post-op period decide if the IOP is high, then you may have to add an AGM. If it is low, obviously you'll want to patch the eye and see, if not take the patient up for suturing. But important end of the case to ensure the wound is well closed. If it has been extended or too much of maneuvering has happened, place one suture. Leave the globe watertight in a patient, more so in a patient who has a complication.
See, most of the cases, some visco will be left behind the IOL and in the anterivitreous area. So, if you don't see the patient more frequently initial days, you may miss this IOP spike. So, I blanket give an anti-glaucoma medication drop for all these patients for the first one week. I see next day, even if the IOP is controlled, I give it for a week and then stop because some IOP spike is possible. And also, we without knowing would have sometimes dropped some thicker epinucleus bit or a bit of nucleus bit and all those. So it may just disappear without we noticing. So after a while, a dilated examination will be a good idea by the retina specialist, especially to check for this and also for the periphery of your retina. So some traction we would have created by some pulling on the tags of vitreous or something. So retina examination is mandatory early, not too late, not too early also.
I think because most of us inject triamcinolone during the procedure to cut the vitreous, it has some amount of anti-inflammatory effect, but at the same time, if too much is injected, that's also very important. If you put too much and everything is going to go into the vitreous, then again that can cause an IOP spike. So you should know exactly when to put the triamcinolone. It should not be too much, but at the same time it should help you to derivate the vitreous.
I just would like to know in cases where manual vitrectomy is done, just small strands are done, what I recommend the residents to do is at the end of surgery, post-operatively for a couple of days, tablet Diamox half BD for 3 days just to keep the vitreous condensed and pull this thing. Is that a practice?
I don't do it. Like I said, I see the patient post-op and then decide because you've also had instances of hypotony, so I don't give. So on first day post-op, if cornea is clear, everything looks quiet, I don't add an AGM. If there is an IOP spike or there is some epithelial edema, then I agree. I think, but most patients, as Dr. Minu and other speakers agree, there is a very high chance of having an IOP spike in eyes with complications. So that is very important for us to manage it, especially if we've had retained lens matter. And there can be some amount of cortex left behind in the bag or in the vitreous, and there is a chance to have an IOP spike. So you can see these patients, if possible, frequently, at least 1 day and 1 week, just to have an idea there's any IOP spike or inflammation has increased. For these two reasons, you may have to see them more frequently.
Actually, the other reason for the IOP spikes is the amount of residual viscoelastics into the vitreous. So that's another reason. That's especially seen in post-iris flow IOLs where printing is sealed off. So whenever you are injecting viscoelastic, especially in the hypotonous eye with the vitreous come out, a lot of visco gets accumulated. And after the iris flow IOL or placing an IOL, if adequate vitrectomy is not done under the IOL and the visco is not removed like it was shown in some of the clips, you may have the IOP spikes with or without with cortex getting dropped inside. So whenever you have got a prolonged spike of IOP, which doesn't usually settle within 1 or 2 days, you should suspect that it's either due to residual cortex, residual visco, or both together.
Yeah, next question, please.
What is your take on pars plana vitrectomy for all the cases where there is vitreous loss?
Yeah, so I personally don't think it is necessary. So you can do an anterior vitrectomy. In my personal opinion, I think it is safe, but we'll have to remember the principles of vitrectomy. So you can't give traction on the vitreous base. So you will, but if one does, an approach to pars plana, that's probably a very good way to approach, but it's not mandatory, I feel. You can do an equally good job through the anterior route as well, through the limbal route as well, but use those principles. Have your incisions the right size for your probe to be introduced. Make sure that you always go by manual. Ensure you cut the vitreous completely. Like I said, have the cutter. So you try to avoid the rise of the vitreous to come towards the probe. It comes like a slinky toy. Rather, if you can have the cutter facing down, you cut and it goes home. Don't move the cutter too much when you are in the cutting mode. Do the movement more when you are in the in the aspiration mode. So having those principles in mind, I think anterior route to me works as well. And I've always been doing anterior approach.
I just want to add a point in case if you are deciding, the midway, if you are deciding to go for a pars plana approach. See, remember you have started vitrectomy and the globe is hypotenuse to some extent. So never make a pars plana entry in an hypotenuse globe. So you always form the chamber and then do it. If you don't follow that principle, what can happen is when you are trying to push the pars plana trocar inside, choroid can also go along with that. So you will end up causing a choroidal detachment when you are making a port. That's something you don't want to have.
All these complicated cases, chances of endophthalmitis, CME, and high intraocular pressure is very high. So I think the patient has to be counseled to come to post-operative follow-up on time, because sometimes these patients come with a pressure of 50, 60, and it will kill the nerve in about a week's time. So that's very important. Post-operative follow-up, a very close post-operative follow-up is very important.
And also, to be tactful in private practice, you should not make it very obvious that you are being treated differently. The patient who had a Paceren is being called more frequently and is being tested by multiple people and all those. So that will make people more suspicious something has gone wrong. So you can always tell that there is some inflammation or IOP spike or something which needs to be monitored, and they should not be placed along with other patients. I usually mark on the case sheet with the color, red color, and then when they come, they are routed separately and they come go to the vision area and then come into my room fast without waiting in a different area. Then otherwise they will, which day did you get operated? Okay, 1 week later, oh, I am called third time now. No. So that is all to console the patient and also make things smooth for you. You would have done a very good job in this, but then they will realize that something gone wrong, and then that will be in their mind and attribute all the other irritation, watering, all those symptoms to something which has happened, which has no connection to it.
So as regards the pars plana vitrectomy, Madam clearly mentioned that it has a role to play when there is a constant prolapse in cases of PCR. But I think I've heard experts saying that for a zonal dialysis, that's the best thing to do. Because with an anterior vitrectomy, you are constantly pulling the vitreous across the bag, over the bag, and it may not settle down under the bag if you're not doing a good vitrectomy. So the better one is to go pars plana and do it under the bag, and then it settles down much easier than an anti-vitrectomy. So I think pars plana has got a place there.
I'd just like to add on to what Dr. Minu says. He brought up another very important topic on patient communication once you have a complication. So this is again a very sensitive, very difficult thing, and I think a surgeon matures fast enough to handle a complication, but to handle a patient is a different ball game. So it's important for us to do that. And how and when do we communicate is a different thing. But as Dr. Minu said, you'll have to be sensitive, you'll have to be open, but if it's a small rent, everything has gone fine, you don't have to go and complicate things. But if you have changed the IOL or you have any retained lens matter or the patient obviously needs a reoperation, do not hesitate to open up and tell the patient that yes, that the lens we intended to place was not, was not possible. We have changed the IOL design model, whatever, because the support was inadequate, and this is the reason, and we will ensure that you give care. So that transparency is important, but not to overly, make them tell them all if you had a rent and everything is fine. You don't have to go and confuse them, because they will obviously get a little more concerned in those instances. Any other comments or final questions?
And the time taken during surgery also. So generally, sometimes they would have done other eye surgery and it would have finished in 7 minutes, and this would take 25 minutes, and then they will definitely keep watching. People under a drape, they are always listening to things happening and all those. They are aware of all these things. So that also, please mention while it is going on. If it is topical, they'll start getting pain. So please add on paracaine or intracameral lignocaine, and tell patient that this is little too hard, or your machine has to be restarted or something, and it is taking a little time. So tell even bystanders also. They will also feel that he has gone 1 hour back and now he is not at all seen outside and all. So all those has to be communicated in a very careful. You should not be letting your postgraduate go and tell. Postgraduates do, or even nurses and all, they don't realize the thing. They will tell something they are not sensitive. So handle with care how you deal with patients and bystanders when you have these kind of altered surgical, intraoperative, inside the theatre and post-operative regime.
I think we'll have this last question before we close. Yes.
Peripheral iridectomy is required in cases of iris claw lens.
You have to, iris claw you'll have to, iris fixation you don't need, but iris claw yes. So I think if there are no other questions, I think we are reached our allotted time. So I'd like to sincerely thank all the speakers who did a fabulous job. I really learned a lot. Thank you, and thank you all of you for taking the time to be present.